Hello and welcome to Dental Studies Simplified. I am Dr. Ankita and in today's video we will discuss double papilla flap. Double papilla flap falls under the category pedicle flaps, that is rotational flaps. Under pedicle flap we have rotational flaps and advanced flaps. So in the previous video we discussed laterally positioned flap. Now we will discuss double papilla flap, and in the next video we will discuss both the advanced flaps, that is coronally positioned flap and semilunar flap. So for today's video the topic is double papilla flap. Double papilla flap given by Cohen and Ross in the year 1968. Please note, it has a unique history associated with its name and the several authors that performed the technique and proposed the technique, but for simplification and easy understanding, please remember double papilla flap was given by Cohen and Ross 1968. This technique is indicated when we have wide papillary regions on both the sides, because the name itself, double papilla flap, that is why the papilla should be sufficiently wide enough to provide the preparation of papillary flaps, because it is double papilla flap. The pedicle flaps will be prepared from beginning from the papillary region. Why? Because papillary region yields thicker flaps than from the radicular regions. That is why this technique is advised and indicated only when papillary regions on both the sides are wide enough to provide the preparation of the pedicle flap. Now the technique involves the following steps. First is root preparation. Second, incisions. Third is flap preparation, and finally suturing. We will discuss each of the following steps in detail. So, if this is our tooth in concern, so like this, if this is the recession that we are attempting to cover. So the first step is root preparation, and root preparation involves root planing and root biomodification. So root planing to remove all the deposits, tooth deposit, and root surface biomodification using agents such as citric acid, EDTA, etc. So once the root is prepared, this portion is prepared which is going to receive the flap. Now begins the next step. Next step is incision. Here the important point is partial thickness flap preparation is preferable over full thickness flap preparation. Number 15 gauge. Please remember, both the options are available to us, but partial thickness flap preparation is preferable over full thickness flap preparation. Why? We will discuss as we discuss the technique thoroughly. So, partial thickness flap preparation with a 15 number blade. The incisions in its chronological sequence are as follows. The first incision is a V-shaped incision, followed by 2 horizontal incision and followed by 2 vertical incisions which are divergent apically beyond mucogingival junction, far enough fairly into the alveolar mucosa. So the number 1 incision is V incision, second incision are the set of horizontal incision, and third incision are the set of vertical reducing incisions. Please note everything partial thickness flap preparation. So this V-shaped incision is to eliminate the epithelial and connective tissue lining around the resection. So let's say with this tooth here, just only this tooth we will discuss. Now here this is the papillary position here, okay, and this is the mucogingival junction. So our first incision will be a V-shaped incision which should extend far enough apically so that when these two flaps are joined, there shouldn't be any bunching at the apex. So when these two flaps are going to be sutured together, coapted to achieve the root coverage, there shouldn't be any bunching of the tissue at its apex, that is at this apex of this V. So the apex of this V should extend apically far enough so as to prevent any bunching of the tissues at the time of coaptation. So the first incision is a V-shaped incision to eliminate the epithelial and connective tissue lining around the recession gingival margins. Once this first incision is completed, follow the next incision. The next incision are the two horizontal incisions at the base of the papilla. So here, after this V-shaped incision, this papilla, now the horizontal incisions should be somewhere. If we divide this papillary region into a triangle and divide them into two halves, the upper triangular half and the lower half towards the base. So the horizontal incisions should be somewhere near the base into the lower half of this triangular portion so that the papillary tissue is involved, because the advantage of this technique is the papillary region provides thicker flaps. So we want a thick flap, pedicle flap should be thick so as to achieve root coverage. So the horizontal incisions should be into the lower half of the triangular region of the papilla. So followed by these two horizontal incisions, and then the vertical releasing incision should begin from the line angles, proximal line angles, and this is how the flap preparation is completed. In this picture, somewhat like this. Okay. Once these incisions are completed, now incisions are done. The first incision, V-shaped incision, horizontal incisions, 2, 1 on each side, and vertical incisions, 2, 1 on each side. When these incisions, all partial thickness flap preparation with a 15 number blade are completed, now is the time to prepare the flap, that is flap dissection. Sharp dissection is done so as to reflect the flap carefully. There are two steps in flap preparation. First is flap dissection, that is reflection. Partial thickness flap reflection is by sharp dissection, followed by relieving all the tension, because we don't want any residual tension on these mucosal or papillary flaps after the operation, after the surgical technique is completed. That is, post-operatively there shouldn't be any tension on these pedicle flaps, otherwise they will rebound and tend to go back to its original position. So all the residual tension, any tension on these pedicle flaps should be relieved, that is periosteal attachments, muscular attachments, or any connective tissue fibers. So once the flap is dissected sharply, how to perform sharp dissection? That is, insert our 15 number blade at the base of this vertical releasing incision and move apicocoronally. Please note the direction, it should be apicocoronally, and this flap should be dissected sharply, and after reflection at the base, relieve all the attachments so that to eliminate any tension. Once this flap is dissected, when this flap is dissected, we see periosteum. If it is a partial thickness flap preparation, it is periosteum which will be visible after the flap reflection. If it is a full thickness flap preparation, it will be bone that will be visible. So now this is the kind of flap that is reflected. Flap preparation is done, that is sharp dissection and flap tension relieved. Clear? So now is the final step of this technique, suturing. Again, in suturing we have two set of suturings. One is suturing these two separate papillary flaps into one, followed by suturing this flap to its position. So, we will discuss each suturing one by one. First, we will discuss the suturing of these flaps. So, for suturing this flap, insert the suture needle from the outer surface of one papillary flap and from the under surface of the second papillary flap, thereby suturing them together so that they unite at its center and then act as a single flap. So it is like a V which is now brought together and act as a single flap. So after the suturing, they will look like this. So after the suturing, they will look like this. The two papillary flaps, the two separate flaps are now joined by interrupted sutures in the center, and now this acts as a single flap. Now this flap is sutured laterally by periosteal sutures. Of course, partial thickness flap preparation. So periosteum is visible. So periosteal sutures. So these are the two set of suturing. First is the suturing in the center to join the two papillary flaps, followed by next here sling suture to maintain its apicocoronal position, and once the apicocoronal position, that is root coverage, is achieved, perform the last and the final set of sutures, that is lateral sutures, that are periosteal sutures. So if we understand it on tooth, let's say here, with this case, the flap preparation, when they are here in this picture, if you can appreciate, now they are brought here. The suturing in the center is performed, and this is the lateral vertical releasing incision. So the first set of suturing onto the tooth are, first is joining these two flaps by interrupted sutures in the center, followed by one sling suture around the neck of the tooth to maintain the apicocoronal positioning, that is root coverage. Once this position is secured, then perform lateral sutures to secure these vertical releasing incisions. Because it is partial thickness flap preparation, the lateral exposed regions will be periosteum. So periosteal sutures should do the work here. So this is the final step, suturing. So suturing are mainly joining the flap sutures, the sutures that involves joining the flap, sling sutures around the neck of the tooth, and final interrupted sutures laterally. So this completes the technique double papilla flap. Now we will discuss the failures associated with this technique. See, lateral position flap and double papilla flap, both are rotational flaps. The failures associated with both the flaps are somewhat similar with one or two differences. So here the major different failure associated with double papilla flap is this step, that is non-union or separation of the two papillary flaps. This is the major cause of failure of the technique. If this suturing is not performed properly, then there is high chance that the two flaps will separate or result in non-union. Then how is root coverage achieved here? That is why under suturing, joining the flap sutures are most important part of suturing, because non-union or separation of the two papillary flap is the most common failure noted down with this technique. To rectify this failure, the only solution is adequate suturing of the two flaps so that there is no chance of separation afterwards. This is the first failure noted with this technique. The remaining failures are similar to that with laterally positioned flap. That is the mobility of the flap, because mobility of the flap will result in non-linkage of the flap onto the recipient tooth or recipient site. That is why adequate suturing of the flap and assuring immobility of the flap is a must. That is why adequate number of sutures. That doesn't mean we keep on suturing every point. Yes, depending on the length of the flap preparation, few interrupted sutures, that is one interrupted sutures at the coronal portion on each side, and similarly at its base portion should suffice. But if it is more longer then one more interrupted sutures in between these coronal and base sutures should suffice, should do the job. So in any house, ensure that the flaps are immobile. Mobility of the flap will not permit adequate linkage of this pedicle flap onto its recipient site. So this is the another failure noted down with this technique. The third failure is in cases with full thickness flap preparation. As I told you, full thickness flap preparation is not advisable here, because when these two papillary flaps are joined, the two interradicular portions, one on each side, are exposed. And if it is a full thickness flap preparation, the exposed portions will be bone, in contrast to periosteum, which will also have an advantage of providing for periosteal sutures. But if it is a full thickness flap preparation, the two interradicular portion, interradicular bone will be exposed, one on each side, which may progress to dehiscence and fenestration. So, attempting root coverage and creating bone loss, how advantageous is the technique then? That is why full thickness flap preparations are contraindicated or not preferred here. So these are the various types of failure. Failure number 1, non-union or separation of the two papillary flaps. Second is mobility of the flap, and third is in case with full thickness flap. For non-union or separation of the flap, ensure the proper adequate suturing of the two flaps such that there is no chance of separation. For mobility of the flap, adequate suturing in all the aspects, that is the sling suture for apicocoronal positioning, and lateral suturing for immobility. And third, full thickness flap, you should prefer partial thickness flap preparation to avoid the failure associated with full thickness flap. A quick summary of this technique: root preparation, that is root planing and root surface biomodification, followed by incisions, that is a V-shape incision, 2 horizontal incisions and 2 vertical incisions, one on each side. Partial thickness flap preparation, so sharp dissection and reflection, followed by relieving all the attachments and relieving the tension so that the mucosal flap can be adapted onto the recipient site without any tension. Flap preparation, that is sharp dissection, reflection and tension relief, followed by suturing, which has 3 sutures. Suturing the 2 papillary flaps, which is the most important part of suturing. Sling suture around the neck of the tooth for apicocoronal positioning, and lateral sutures, lateral interrupted sutures, which will be periosteal sutures in partial thickness flap preparation. And this completes the topic double papilla flap. I hope this topic is clear to you all. In the next video, we will discuss advanced flaps. For now, we have completed pedicle flaps, that is laterally positioned flap in the previous video, double papilla flap in today's video, and in next video, we will discuss advanced flaps, that is coronally positioned flap and semilunar flap. I hope the topic is clear to you all, but if you still have any doubts or any queries, feel free to ask me in the comment section below or mail me at my email ID dentalstudiessimplified@gmail.com. One important point here, all the viewers, please note, I have personally acknowledged all the requested topics from your end, and I assure you I will discuss all the topics one by one in detail thoroughly. But for now, we will be discussing periodontal plastic and aesthetic surgery. After the completion of this topic, I will take up all the requested topics in its order of receipt. Okay, so I hope the topic is clear as of now. Thank you for watching and listening to me. Study well. Have a good day. Stay safe.